Welcome back, everybody, to IPHA's Interprofessional Health Talk, which is an interview series focused on showcasing interprofessionalism through insightful discussions with various professionals and students within the health sector. We hope to expose students to different career paths and skills so that they can make a more informed decision about their future. My name is Janna.
And I'm Herneet. Our guest today is a clinical research project manager and a scientist at the Hospital for Sick Children in Toronto, and has also done research in neuropsychology, nutritional biochemistry, and physiology in children and adults. Welcome, Dr. Patel. It's so great to have you here.
Well, thank you so much for having me.
Of course. So I think we can jump into the questions.
Sure.
To start, we wanted to ask you if you could walk us through your undergraduate experience within your program and how all of that went for you.
Sure. So it was a long time ago, but I completed my honors biology degree at McMaster University in Hamilton, Ontario. And so I was really excited about kind of experiencing all there was to experience in undergrad and within the science faculty. So I was really lucky because first year I was able to take a science inquiry course. And I think that really laid the foundation for my interest in research. So it was like a course where what we did was kind of come up with really novel and exciting research questions about anything we wanted. And then we figured out the best way to solve them. Mm-hmm. And so we worked individually and we worked as teams. And it was just really cool to kind of look at all different aspects of science and, come up with like really cool ways to solve really exciting questions. And I also had the ability to take because I did biology, I also had the ability to take a number of electives. And so I was able to minor in English. And so that was really cool because I think it really helped in terms of my writing and reading abilities. And it was kind of a nice balance to have like the humanities and then the science as well. And to not just have all these hardcore kind of science courses, but to do something that was more, geared towards a different type of thinking. So that was really cool. And I kind of encourage that, I think, in people's undergrad experiences, if they have the opportunity to take different electives sort of outside their field of interest. I think that's really important. And then I kind of ended off my undergraduate experience doing you had the option to do a fourth year senior thesis. And so that was really exciting because I think that really propelled me into a scientific career, particularly graduate studies. Because the supervisor that I worked with ended up being my master's supervisor. So it was really neat because I was able to focus on learning as many skills as possible. I got to work with him over the summer before we started at York. And so it was really kind of an interesting experience doing a lot of scientific stuff, but also, getting the chance to have more of a well-rounded experience.
Mm-hmm. Of course.
To showcase your research even further, for everyone listening in or viewing through YouTube, we do have an interactive part coming up. So Dr. Patel is just going to showcase her research. And if you're listening in through our podcast, we're going to upload the visuals on YouTube.
Okay, awesome. Okay, so I'm currently I'm at Sick Kids. I'm working with a couple of different researchers on a grant that we recently got funded from the Foundation for Prader-Willi Research. And so we're looking at chronic stress, cognition, and food cue reactivity in Prader-Willi syndrome, or PWS. And so Prader-Willi syndrome, or PWS, is the most common genetic cause of life-threatening childhood obesity. And it results from an absent or dysfunctional gene in a region on chromosome 15. And when it's diagnosed, its presence is characterized during childhood by short stature, by cognitive impairments, and hyperphagia, or excessive appetite. Individuals with PWS have, like I said, are hyperphagic. They have a difficulty feeling satiated after having a meal. They're also known to have higher levels of stress or anxiety, So a lot of them report obsessive compulsive disorders and just high levels of anxiety in their daily lives, as well as cognitive deficits, like I mentioned previously. And so without intervention or treatment, this excessive eating or this hyperphagia can lead to excessive weight gain, as well as to life-threatening diabetes. And so some of the complications of having PWS is that this food compulsion requires constant supervision, usually from the parents or from the caregiver, because some individuals can develop serious life-threatening GI complications because of binge eating. So what happens generally is kids are on a routine of when they can eat. So they're on a very structured sort of meal plan. They're not allowed to sort of eat ad libitum or eat as much as they want at a time. They're given like set meals. Usually I would say for some families, in some cases, like cabinets and fridges are locked to prevent them from going inside and sneaking food. So that can happen as well. Some kids will even sneak food off the other people's, like their family members' plates or from the garbage or green bin. This happens not in every case, but with some kids. So it's very important that the caregiver and the physician treating the individual sort of monitors how like food is restricted in their home. And so the individuals with PWS generally don't have, the ones that are treated well don't really have severe obesity because of this, but the ones that do, who are not sort of following a structured routine, are at higher risk of things like hypertension, diabetes, respiratory problems, and other conditions in adulthood. So PWS is diagnosed using both clinical evaluation and genetic testing. And this is done through things like DNA methylation or fluorescent in situ hybridization. And then treatment usually involves, I would say, it's sort of headed by or organized by a pediatric endocrinologist, and then as other members of an interprofessional team like geneticists, other pediatricians or family doctors, speech therapists, other people like dietitians as well are important for maintaining an eating schedule, and also creating an effective program that works for the child and the family. And of course, this differs depending on the disease severity and symptoms. So we'll see like cases where people have very severe PWS and cognitive deficits or obesity, and then other kids that are managing a bit better. So just to kind of go through how we measure these things. So what we do like during our visits, we have kids come in for a blood draw. So this is done fasting at sick kids. So they come in, they sit down, the nurse takes their blood, and we measure their appetite hormones. So we collect their bloods into vacutainers or these little tubes, and we process them with different inhibitors if needed, and then we spin them. So we're really looking, we either spin them or we let them clot. And if we spin them, what we're getting is plasma, which is what we're interested in collecting, which we freeze and store. And if we let the blood clot, then we're getting serum, which we then spin. And after the blood clots, we spin and we get serum. And then we also store that for whatever marker we're looking at. So these are the appetite hormones. We also have the kids sit down and we give them a bit of a haircut. Not really a haircut. We just take a sample of their hair from the back of the head for collection of hair cortisol. So it has to be done kind of really close to the scalp, which is more difficult on boys than it is on girls, but we manage to get as much as we can. And then this is weighed and then extracted and then analyzed for cortisol. And this is actually a technique that's being done by one of our collaborators at Western. So not done at sick kids, but with someone offsite, which is kind of cool.
I just have a little question. Why do you have to cut the hair from the root?
Because hair grows at a certain length, like a certain amount each month, I believe. And so when it grows from the root, that's when you take a certain amount, you can kind of get a sense of like how much cortisol is being produced over that period of time.
Okay.
Because if you took it at the bottom, you wouldn't know like what the actual amount was because there's so much hair.
Okay,
Does
that
that make
makes sense.
sense? Yeah, because it's like it's growing and then you're basically not secreting cortisol, but you're like the cortisol is within that new hair.
Okay.
Or the hair that's coming out, I should say.
Okay.
Okay, and so after all of the blood and cortisol stuff, they go on to have a brain scan. So we use a technique called magnetoencephalography, or MEG, which is kind of cool. Sick Kids is one of the I don't know if it's one of the only places in Canada, but there's very few machines, MEG machines, I think, in the country. And Sick Kids is one that has one for kids. And so it's a brain scanning technique that's used to examine the relationships between brain areas at rest. And so what we were looking at is sort of the connections between these brain systems, or brain areas, and how they change and respond when they're looking at these, or when they're performing different tasks in the scanner, or looking at different pictures in the scanner. So when they're in the MEG, and the MEG is not painless or invasive in any way. It's like basically like wearing a helmet, and so it's very user-friendly, I would say, compared to something like an MRI. So one of the tasks that I'm particularly interested in looking at, because I'm a nutritionist, is the food cue reactivity task. And so this task has kids look at pictures of high calorie food, or low calorie food, or non-food. And so we want to see basically whether or not there's areas in the brain that control food intake, or are responsive to food intake, are differentially affected by whether the food is high versus low calorie compared to the control, which is the non-food image. And so we think that kids with PWS are going to have more of a heightened response to the high calorie food, because it is more palatable, more something that you want more than something that's healthy, to be honest. And so the next task is called a go-no-go task, and this is measuring response inhibition. So if you look at the baseline condition here, when the kids get a button box, or like for playing video games, and so they're told to like press on a button when they see a shape without an X. So they see a shape without an X, and they press. When they see a shape that has an X, they don't press. And so this happens over time. So I think it's a period of like 12 minutes maybe, where they like see images flashing, and they press or they don't press. And so it becomes increasingly harder because you are so used to pressing that it's really hard to stop yourself from pressing. So in the inhibition condition, you see there are more goes. And then when there's a no-go, it's really important to see whether or not that person is able to inhibit that response. So stop yourself from pressing. And so we think that the thought is that kids with PWS are not going to be able to perform as well on this task than kids without PWS. The other task, so we get a lot of tasks in the scanner, but it's actually not that long of a period of time, is an emotional processing task, where kids look at pictures of faces expressing different emotions, and then the control is like a blurred face. So they see just the top image, and then there'll be a rest period, and then they'll see the bottom image. And so again, we don't know much about emotional processing in PWS, but we think that there might be impairments there as well. So that's kind of a more of an exploratory sort of outcome for us that we're interested in looking at, that has not a lot of people have sort of looked at, particularly in this population. And then the last thing, this is not part of the MEG actually, this is separate, is the kids, both the PWS kids and the kids without, will complete a set of neuropsychological tests with the clinical psychologist. And so again, they're looking at things like full-scale IQ and attention and decision making, I think, and a bunch of other really important sort of neuropsychological testing that you would see a psychologist for. So we're actually doing this within the study, which is really neat. And then being able to compare it to controls, and then also with what we find in the brain scan. And so the study is ongoing. So unfortunately, we don't have any interesting findings to share with you right now. And COVID, of course, has kind of delayed us getting subjects in. But what we hope to find is that our results will help us increase our understanding of how these different brain regions that are involved in food intake are related to appetite hormones and cortisol and neuropsychological performance in PWS, so that we can provide a foundation for developing effective dietary and cognitive treatment strategies to manage feeding behaviors and stress in this population. So that's the study.
Yeah, that's really, really interesting. Perfect. Yeah, thank you.
I think those are all our questions, unless you have anything else you'd like to add.
No, I hope that covers everything that you wanted to hear.
Yeah, it was very, very helpful and really interesting to hear about as well.
Awesome.
I think we can do the closing remarks now. So Dr. Patel, thank you so much for taking the time to talk to us today. It's been a really great conversation, and we have learned a lot from you. And also, I'm assuming that everyone listening will also learn just as much. On that note, thank you to everyone tuning in to another episode of Interprofessional Health Talks. We hope that you've enjoyed this episode as much as we did. And as always, you can find us at UOttawa ITHA on our social platforms. Have a great week. Thank you again for joining us.